هنبدأ بالفيزيولوجي. هنبدأ بس two lectures for physiology اللي هي coronary circulation وبعدها cardiac output. الحمد لله coronary circulation سهلة جدا، بس في شيء صعوبة عن pressure gradient. وبعدين لما نخلص pressure gradient هنلقى باقي المحاضرات or the rest of the lectures for coronary circulation very easy إن شاء الله. So let's begin. Obviously when we begin with the first slide, this is first slide from anatomy before. I'm not going to get into it. Obviously from ascending aorta to coronary arteries. طبعا حاجات basic والvenous return, anterior cardiac vein, coronary sinus، وفي ثالث واحدة اللي هي الفينو كوردس مينيمي اللي خدناها قبل كده، drain to the right atrium. حاجات يعني basic عرفناها من anatomy. اوكي هنا حنبدأ من هنا من شوي. فالcoronary blood flow at rest بتكون مش بالليتر بالمليليتر 225 to 250 milliliters per minute. لو حولناه الى الليتر بتكون 2.5 liters، ف 5% of the cardiac output. تمام. الكاردياك اوتبوت بالافريج بتكون 5 liters ببساطه، فتخيل دي تكون 250 milliliters، خليها 2.5 liters مثلا، والافريج 5 liters 5%. هي so the heart takes this amount of blood 250 milliliters. However, from the blood it extracts how much oxygen from these 250 milliliters of blood? 60 to 70% of oxygen. Now the other tissues they extract only 25%. Now you're probably thinking logically, of course, because of its muscle contraction it requires huge amount of energy, but for a physiological reason you could say the reason why the heart requires this amount of oxygen extraction is because due to its mitochondrial content. The heart has pretty much depends on one of the three energy systems, the oxidative phosphorylation, where mitochondria is needed, formation of energy in the presence of oxygen, طبعا. And of course, it gets this energy or it gets this oxygen through blood. And the only way to get more oxygen in something like exercise, for example, or in fever, the only way oxygen delivery to the heart as a result of this high amount of mitochondrial content is by increasing the blood flow. You want to do vasodilation of the arteries and you want to do venoconstriction of the veins. We'll get into that in the next lesson about the arteries and veins. Tamam? And one very simple difference is that you see with the heart, when it says 60 to 70%, it means it needs all of that 70% of oxygen. It literally needs it. While other tissues like the skeletal muscle, when they take 25%, they treat it like a reserve, like a storage. It will take 25%, it'll use a small amount of it, and it will use even more oxygen during exercise. So that's a bit of a small difference. And of course, skeletal muscle has different energy system, yada yada. Simple stuff, okay? So let's look at the blood flow of the heart during systole and diastole, okay? So let me draw the heart real quick. If I draw the heart, just imagine this is the entry or the pathway to the aorta right here, the aortic valve. Let's imagine this, or let's have this one. Now let's have this one closed and this one closed, all right? Right atrium, right ventricle, left atrium, and left ventricle, okay? So let's talk about the blood flow when there's ventricular diastole or systole. We always talk about the ventricle when it comes to systole and diastole. So here's the thing. When the ventricle contracts, all right, when the ventricle contracts, has more pressure than the aorta. Do you guys remember the position of the arteries in the coronary arteries? Like one over the circumflex artery, the anterior interventricular artery, the right coronary artery, they're all over the myocardium. So from an anatomical perspective, when the ventricle contract, they actually compress the arteries. So if I want to draw it in black, just to further highlight it. When the left ventricle contracts, they will actually compress the coronary arteries. And when you compress the coronary arteries, there's going to be reduced blood flow because you're constricting it. You're constricting that little blood flow during systole. This occurs in the left ventricle and this occurs in the right ventricle. However, during ventricular systole, the blood flow is going to be more in the right ventricle as compared to the left ventricle. And the reason why is simply because pressure gradient. Pressure gradient. That's the first reason. The second reason is the open aortic valve. When the valves open, as we know, the coronary arteries, they arise from the ascending aorta, and the valve pretty much the gatekeeper. So when the valve open, they may partially block the entrance to the coronary vessel. But I want to focus on the first reason, okay? So when blood pretty much comes and pretty much ventricle contracts and pretty much blood comes towards the aorta. Let's say the left ventricle, let's say the pressure during ventricle systole, say this is systole. Let's say during ventricle systole, the left ventricle is 121 millimeter per mercury in terms of pressure. And let's say the aorta is 120. Now, here's the thing. The blood flow towards an organ is going to depend on the pressure gradient. When we say pressure gradient, I mean the pressure difference. The greater the pressure difference, the greater the blood flow. For example, a difference between 20 and 10. What's the difference between them? 10. So let's say this is from one organ to another, the blood flow. Now, there will be blood flow, increased blood flow. However, if I compare this to another type of blood flow, like, let's say 110 on this side of the vessel, and let's say in this one, it becomes, let's say around 50, okay? 50, and this is around an artery. From one artery, from the starting end of a vessel to the end. Now, the difference between this is around 60. The pressure is 60. So in both of these arteries, this artery number 1, artery number 2, there's going to be increased blood flow from the left side to the right side. Or from the right side to the left side. But the difference is that in artery number 2, there's an increased blood flow compared to artery number 1. Why? The pressure difference. The pressure is greater on 110, which means more blood can flow towards the other side. So that's because of the pressure gradient. Now, if we can see right here, during ventricle systole, alright, so if I can get my eraser, during ventricle systole, the pressure between 120 and 121 in the left ventricle is -1. -1. So what does this mean? There's going to be no blood flow to the ventricle during systole. So imagine these is your circumflex artery, your interventricular artery. No blood flow is going to be to the right ventricle. However, the pressure in the right ventricle, let's say this is 25 during systole, okay? During systole, the aortic pressure is way greater than the right ventricle. 120 minus 25 becomes 95, a pressure gradient of 95, positive 95. So as a result, blood flow is going to be reduced, is going to be stopped for the left ventricle during systole. However, there's going to be increased blood flow to the right ventricle during ventricular systole. Why? Because of the pressure gradient. And this is also number one reason why blood flow is reduced to the left ventricle. Okay? So, this is about the blood flow. And of course, the second reason, we've talked about it before. And we've talked about, here's the graph, you can look at it as well. Here's the graph. The pressure difference between them is greater during systole than diastole. Therefore, more blood occurs to the right ventricle during diastole. Okay, what about diastole in that case? Well, and what happens is that we can just scratch this out. If we want to, let me get an eraser. Just scratch this piece out. Just take this out. Take this out. And we're going to just draw it again. Simply, there we go. All right. So during diastole, all right, during diastole, it's very simple. During diastole, the left ventricles or both ventricles relax, right? So when they relax, the pressure will decrease. It will decrease enough for what to occur, for the aortic valve to close. And if it closes, that means that the ventricle pressure in both the right and left have decreased. Let's say both of them are 0. And when they're 0, what happens to the coronary arteries first? They'll be not compressed. The perfusion will increase. But what about the pressure in the aorta? The aorta is still, let's say it's around 80. All right, say it's 80. So as you know, the artery is elastic. So when the aortic valve closes during isovolumetric relaxation, when it closes and is being elastic, it has a bulge created. So as a pressure reservoir, what happens is that now it's going to expel all this blood towards the coronary arteries. It was 120 and during systole, and now it reverts back to its original pressure 80 due to elastic recoil. And this 80 in aortic pressure is obviously greater than the right ventricle and the left ventricle. The right ventricle will still keep adequate blood flow to it. And of course, the aortic pressure is now greater than the left ventricle. That means blood flow can finally come towards the left ventricle. So what does this prove? This proves that blood flow to the left side of the heart occurs during diastole and not during systole. Okay? And what I just explained right here is one of the main factors that affect coronary blood flow is the pressure. There's two other factors. We'll link to it later on. Okay? As we see, is the pressure. You can see the table, the difference and whatnot. And if you want to talk about the notes right here, all what I was saying about the pressure difference in the aorta and the ventricle, this is known as coronary perfusion pressure. This entire thing talks about coronary perfusion pressure, which is the pressure difference between the aorta and the ventricle during diastole, okay? Which allows increased perfusion pressure or blood flow. That's pretty much it, okay? So this is one of the factors of coronary blood flow, which is talking about the pressure. And now in the next slide, it pretty much talks about why this region of the left ventricle, the subendocardial region, the small little region overlying the myocardium, this subendocardial surface.
Nawab,
Hello.
the graphs, can you go back? Because those are like nightmares to me, like the previous slide.
This
Can
one?
you just go through the explaining of them? The previous slide.
This one?
12, bro.
Okay, so let me look at this graph. I never paid much attention to this graph, but from what I see, the aortic pressure, this is pretty much...
It's not visible, Sultan. Can you... Yeah, Nawaf. Can you just click on it? 16. اللي تحتها.
أي slide بالضبط؟
12.
أيوة في 12.
Yes, this one.
All right, this one. Okay. Okay, so let me have a moment. Okay, so let me start with the aortic pressure. So the aortic pressure decreases. This indicates this is during diastole. The aortic pressure will decrease, and this is obviously during systole, ventricular systole. It will increase up to 120. Okay, so up to this point, we know where this is occurring. We also know where this is occurring. This is talking about the coronary blood flow. Which is talking about the amount of blood in the coronary arteries. So let me see. Okay, this is definitely during diastole. It's definitely during diastole. So it's pretty much the same thing, the systole and systole. So pretty much during diastole, the aortic pressure will decrease and the coronary blood flow will start to decrease. Because why? Because it's sending to all the other sides of the heart. This part right here. During systole, ventricular systole, the aortic pressure will increase. The coronary blood flow will start to increase. The amount of blood in the coronary arteries will start to increase. There's increased blood flow towards the rest of the heart. And then what I believe what happens next is systole again. Not systole, diastole again. So this is in the beginning of diastole, where the left coronary artery obviously gets more blood flow than the right coronary artery. So this is ventricle diastole. Left coronary artery has more blood flow compared to the right. So more left ventricle blood supply properly. And then we revert to the same process all over again. So this is at the beginning of diastole. This is at the end of diastole. Then systole, then diastole. Is that clear, Abdul Majid, or I can repeat it?
Yeah, take it off. Shukran.
No problem. So this is pretty much talking about if you compare it to the cardiac cycle, it's much easier. All right. Let's delete some of these. Okay. So we were talking about the subendocardial surface of the left ventricle. And this is pretty much tells you why the subendocardial surface of the left ventricle is the most common site of myocardial infarction. It's because the subendocardial surface, it's very small and it's very thin, it's barely visible. And during systole, the blood flow is almost not there, so it's easy, very easy for myocardial infarction to occur over there. That's pretty much all there is to know, okay? Let me get an eraser to delete this part. There we go. I'll draw some of these again, no worries. And now it talks about, okay, so up to this point, we've known about the factors that affect the coronary blood flow, which was the pressure, right? So what are the effects of tachycardia on the coronary blood flow? Okay, so let me draw this one more time, very quickly. Okay, so let's have the eraser to delete the pressure gradient. There we go. Perfect. All right. Now let's have the aorta. All right. Okay, Shabab. So we've said before that the ventricular systole, when the ventricle contracts, blood flow to the left ventricle will not even be there. The blood flow, it was there properly during ventricular diastole. However, during systole, it will be stopped. Why? Because we said the aortic pressure and the left ventricle pressure, the pressure difference between is -1. So there will not be any blood flow to over there. Okay, so if it's getting its blood flow during diastole, then what about tachycardia? You guys remember tachycardia, how the cardiac cycle, let's say it was CC, let's do CC. Cardiac cycle, at rest, when you have 75 beats per minute, it lasts for 0.8 seconds. So if you're doing exercise, for example, if you're doing exercise, the cardiac cycle will actually decrease to 0.6 seconds, for example. Why? Because this needed exertion, this needed oxygen demand is required for exercise. So tachycardia, increased contractility, increased heart rate. Basically, your sympathetic system will activate, and the systole is going to be decreased, but mainly the diastole. Why? Because you guys remember the ventricular part of 0.8 seconds, right? Ventricular 0.5, diastole 0.3, systole. So in tachycardia, the diastole is going to be decreased, all right? Let's say around 0.4, for example. Makes up 0.6 in total. So the question is, the point of this slide is, okay, why do we not suffer from myocardial infarction? If the left ventricle demands on coronary blood flow during diastole, and in a case like tachycardia, diastole is reduced, why do we not suffer from myocardial infarction immediately during exercise? And the answer is, the pressure gradient, ya shabab, is not the only factor. The pressure gradient is not the only factor that affects the coronary blood flow. We have other factors that occur during exercise for the heart that affects the coronary blood flow and ensures that the left ventricle is getting adequate blood supply. And same goes for the right, but mainly the left ventricle, okay? And we'll see what these two factors are. The chemical factors and the neural factors, along with the pressure gradient. These two factors prevent something like a myocardial infarction during exercise, and they correlate with one another. It also says here that coronary blood flow shows considerable ultrarate regulation. Basically means it can regulate itself. It doesn't need, sometimes it doesn't need the help of sympathetic system. Sometimes it has other regulations. Now let's look at before we look at the chemical factor real quick, let's look at an example of decreased blood flow to the left ventricle. Before we start with the chemical and the chemical and the neural factors for coronary blood flow, let's talk about a case in which there's decreased blood flow to the left ventricle. So a decreased blood flow to the left ventricle, for example, aortic stenosis, obviously. So in aortic stenosis, shabab, obviously the stenosis, it will be unable to open properly. So it's going to be a whistling sound. And what happens is that since blood has trouble, all the blood that the left ventricle during contraction, all this blood has trouble going through the aorta, and there's part of it that's not open properly, the pressure in the left ventricle is actually going to be very high. It's going to be higher than usual because it's compressed. This aortic valve is not opened. So what do you think happened to the coronary arteries? They will compress even more. That's number one reason. They're going to compress the coronary arteries even more. The second reason is after diastole, let's say during diastole, what about the pressure in the aortic? The aortic pressure during diastole is going to be low. Why? Because it didn't get an adequate amount of blood from the left ventricle during contraction because of this aortic stenosis. So the diastolic pressure in the aorta is low, and we've said before, shabab, let's say instead of 120, this becomes 80. Or actually, no, let's say this becomes 60. The pressure in the aorta was 60, and this was 0. There will be blood flow to the left ventricle. Don't get me wrong. There's still blood flow to the left ventricle and right ventricle. However, there is decreased coronary blood flow, reduced blood flow. And that's the point. Aortic stenosis is an example. Simple as that in a case like this, okay? So now we will talk about the chemical factors. What prevents tachycardia? What prevents myocardial infarction or in a case like tachycardia, okay? And that's the chemical factors and the neural factors, and they correlate with one another. Let's talk about the chemical factors. Okay, So there are chemical factors that cause vasodilation. So let's consider them as vasodilator metabolites, such as the lack of oxygen, increased concentration of carbon dioxide, hydrogen, potassium, lactate, prostaglandin, adenosine, most importantly, and adenine nucleotides. These increased concentrations, these first four, you could say, they come from metabolism. They usually indicate they come from metabolism or aerobic metabolism, waste products. So, for example, Shabab, when your left ventricle contracts, it usually releases adenosine from like ADP. You know, it's using ATP for contraction, using oxygen from it, and it releases adenosine, for example. And this increased concentration adenosine can go to the blood vessel and cause vasodilation. Maybe increased concentration of potassium, hydrogen, carbon dioxide, even lack of oxygen. Tamam? So we got chemical factors that are mainly regulated by, not mainly regulated, but mainly controlled by our sympathetic system, which is the neural factor later on. I want to explain the neural factors first, because it has a relation with some of these. So as you guys know, the neural factors, sympathetic and parasympathetic system, we're only going to talk about the sympathetic because parasympathetic, has a weak effect, is kind of irrelevant. So we'll focus on sympathetic. And as you guys know, there's alpha receptors and beta receptors. The majority of sympathetic receptors in the heart, Shabab, is beta 2. And there's beta 1, my bad. Beta 1 receptors. And there's small amounts of beta 2 here in the blood vessels and small amounts of alpha. So basically, what beta 1 receptor does for the heart, the majority receptor in the heart, what it does, it causes indirect vasodilation. But its direct effect is to, when norepinephrine or noradrenaline, when they get released by your brain and they go to the heart, norepinephrine, noradrenaline does not have a specific goal. They will choose any receptor that's the majority, and it will do this effect. The majority receptor is beta 1. So they'll activate beta 1, and what beta 1 receptor does is it will stimulate heart rate, stimulate force of contractility, your strength of contractility, increase heart rate, increase contractility. While alpha receptors found in blood vessels, their main mechanism is vasoconstriction. Okay. Now I will get into chemical factors, what it has to do with neural factors. But here's the thing about sympathetic stimulation. Sympathetic stimulation is this direct effect. Its main goal, Shabab, its direct effect is actually vasoconstriction for the coronary arteries. That's its goal, kind of. But the problem is that, not problem, but the good thing is that when norepinephrine and epinephrine goes to the heart, it actually causes vasodilation instead. How? Why? Because of this beta 1 receptor and because of these vasodilator metabolites. Here's what happens. So let's say in an exercise, imagine I'm exercising. And imagine my heart will obviously have to compensate, is going to need more oxygen, more energy demand to keep up with the increased workload. So your heart is going to go under tachycardia. Let's say 130 beats with more contractions. So pretty much sympathetic stimulation, norepinephrine, and epinephrine is going to go to any receptor in the heart. Alpha 1, beta 2, beta 1, but the majority of receptors are beta 1. So the action is going to be acting mainly on beta 1, which does what? Increase heart rate and increase heart contractility. Now, here's the thing, right? Didn't I say before that the vasodilator metabolites, didn't I say before they come from metabolism? So when the heart contracts, when it's actually using oxygen in its mitochondria to synthesize ATP, this ATP is going to give waste products in the end of this metabolism. Waste products. It's going to release waste products. And waste products such as adenosine from ADP. So there's going to be release of vasodilator metabolites as a result of contraction at the end of it. Is all this? Let me draw in yellow. So all this vasodilator metabolites, Shabab, all of it's going to be released to the blood vessel. And when they get released to the blood vessel, what will they do? They will cause vasodilation. How? Do you guys remember nitric oxide synthase? One inflammatory, one endothelial, one neuronal. This one is going to be acting on the endothelial cells of your blood vessels. It's going to activate the nitric oxide synthase that is found in the endothelial cells. So It will stimulate. And what does nitric oxide synthase does? Stimulates nitric oxide. What does nitric oxide does? Vasodilation. Goes to the smooth muscle cells in the media. Boom. Vasodilation. So what did we learn from all this? Its direct effect on sympathetic on coronary arteries is vasoconstriction. However, because the majority of sympathetic receptors in the heart are beta 1 and adrenaline goes to any receptor it can find, the majority being beta 1, it will stimulate beta 1, and sympathetic stimulation indirectly causes vasodilation. So, Shabab, this is a lifesaver during exercise. This is why you don't have any myocardial infarction. This is called vasodilation in the coronary arteries, good blood flow for your left ventricle especially. Tamam? And of course, let's say for example, I just want to include one more thing, okay? During myocardial infarction, another thing that causes vasodilation, when there's no oxygen left, your body will go to what is it called? Anaerobic glycolysis. Anaerobic glycolysis will synthesize ATP, but it will also synthesize lactate. So lactate can come in and be a vasodilator as well. All right, so it's not much of a problem. Just an example, but that's pretty much it. This is why the direct effect is vasoconstriction, but it still causes vasodilation. That's its indirect effect, Shabab. Okay, and we see it right here. Stimulation sympathetic nerve, epinephrine, increase heart rate and force contraction by activating beta 1 receptor, the majority. Indirect release of vasodilator metabolites, vasodilation. And we can prove this is direct effect. How? When we study pharmacology, Shabab, you will see in beta blockers, and this is exactly why we can't use beta blockers for a type of angina pectoris, which is Prinzmetal variant angina. We can't use beta blockers. Why? When we block the beta receptors, beta 1 and beta 2, by like beta blockers, when we block it, we leave the alpha receptors untouched. And what do they do in the blood vessels? Vasoconstriction. So if they cause vasoconstriction, that means we know its direct effect is vasoconstriction. And that means in somebody with Prinzmetal variant angina, which is caused by coronary artery spasm, we cannot use it. We'll get into it in pharmacology, but this is the direct effect. And we pretty much finished chemical factors and neural factors. And we'll go to the benefit. But Shabab, I'm going to restart the meeting, by the way, because my meeting is going to end in 1 minute. I have a 40-minute time, right? So I'm going to restart the meeting and send a new link, and you guys can join. I just realized. We're going to continue from slide 22 about the benefit of sympathetic stimulation indirectly, okay? I'll start the meeting again. It's going to end in 1 minute, okay?
Okay.
بس انتظر دقيقتين عشان يجي الكل يدخل وراح نكمل. أكمل بعد دقيقة. 7:50. طيب خلاص يلا نبدأ نكمل. نكمل 7:50 يلا. So we started, we continued at pretty much the effects of the neural factors, the direct and the indirect effect, the chemical factors, what it has in relation to it. So we want to talk about the benefits. We want to talk about its life-saving benefit in cases like tachycardia and during exercise, right? Where tachycardia occurs. What about in, let's say, septicemia, septic shock? Tamam? So let me get the drawing. There we go. So in cases like sepsis, and we've taken this in microbiology, I don't want to go into too much detail. We'll know it in microbiology, but basically in septicemia, there's going to be vasodilation due to inflammation from inflammatory cells cause vasodilation. And at some point, the vasodilation, Shabab, the vasodilation can be a little bit too much. You know, there's edema, chemotaxis, it can be a little bit too much. And as you guys know, when there's too much vasodilation, as you increase the radius of a blood vessel, pressure will decrease. At some point, the pressure might decrease way too much. And it gets to the point that we have receptors, we know them from physiology after mid-2 called baroreceptors. We'll know it later on. But basically, we got receptors that activate the sympathetic system in order to restore this blood pressure. It doesn't want it to be too low. You want the blood flow to keep going. This would actually decrease the blood flow, too much vasodilation. You want it to keep going, have some movement, have some speed. So you want to increase the systemic blood pressure. The sympathetic system will attempt to increase the blood pressure during shock. How? By doing vasoconstriction. So this was vasodilation, Shabab. This is vasoconstriction. Vasoconstriction in order to restore the blood pressure. Now, how does it restore the vasoconstriction? We said alpha in the blood vessels. In the majority of the body, really alpha 1. They don't have beta 1. Beta 1 receptors, beta 2, but they have alpha 1 receptors. The noradrenaline, they'll activate the alpha 1 and cause vasoconstriction, except one organ. For now that is. And that is the heart. The heart, we said it before, the indirect effect, instead of vasoconstriction, vasodilation. And this will increase the coronary blood flow secondary to metabolic changes in the myocardium. This way, circulation for the heart is preserved while other organs is compromised. I say for now in septicemia, because you'll find out in microbiology, this will occur in the heart for a while. The heart will be fine for a while until the septicemia spread to the coronary arteries. But for now, the heart is saved, okay? That's the second benefit of indirect effect. And of course, it goes into a little bit more detail during ischemia, Shabab. Of course, the cardiac muscle will go to the other energy system, anaerobic glycolysis, which can derive energy, however, is not everlasting like oxidative. It produces also lactate. And if I mix it up with microbiology, when there's lactate, high amounts of lactate, we call this lactic acidosis. And lactate, being an acid, it could decrease the pH, make it acidic, and activate lysosomal enzymes. And these lysosomal enzymes will damage endothelial cells and any nearby cells, which is why, Shabab, this is one of the causes of cardiac pain. Also calcium, but we'll get into calcium later. We're not getting into it now. We'll get it in pharmacology. But for now, if you want to know the reason, it's due to lactic acidosis. Activate lysosomal enzymes during myocardial infarction. Now this one I'll ignore. This one I'll leave for pathology. This one doesn't need this. This is all pathology in better detail. The only thing really, Shabab, the only thing we need to know, if personally, is, and even the ST segment, elevation, depression. If you guys want to know the reason for ST segment, if it's depression, elevation, of course from pathology, ST depression relates to which type of myocardial infarction? Subendocardial infarction, a non-transmural infarction. While ST elevation refers to transmural infarction. That's two types of myocardial infarction. We'll get into it in pathology, even that one. The only thing we need to focus on, Shabab, for the rest of these slides is the investigation, even some of it from biochemistry, ECG, cardiac enzyme, but these two as well. These four as well. Just memorize them. And we'll memorize also the treatment, even treatment from pharmacology as well. But we want to memorize the extra three: angioplasty, some device to dilate the artery, stent, and bypass surgery. Okay? That's it. And that's the rest of this lecture. None of this is with us in the mid-exam. Any questions? If not, I can go to the next lesson. If you have any questions, just let me know. I can answer you anything about physiology. Inshallah, it'll be more clear. That's the end of the first lecture. Okay. So now I'm going to start with cardiac output. If somebody talked, my headphone was not on. Anyway, I'm going to start with cardiac output, okay? Now, with cardiac output, about 33 slides. Don't worry, we're going to make it much easier. But first, let's start with the definitions, okay? The first lesson was easy, right? Now let's talk about the cardiac output. The cardiac output is also easy, Shabab, but it takes a little bit of concentration because it can be a little bit way too confusing, okay? So what is cardiac output? Cardiac output, bibasata, is the volume of blood pumped out by the ventricle per minute. How much blood can the ventricle pump in 1 minute? And of course, we said the average is 5 liters. 5 to 5.5 liters, okay? And in cardiac output, Shabab, in order to calculate it, you can not calculate it, but pretty much what does it revolve around? The cardiac output revolves around the heart rate and revolves around the stroke volume. And these two, Shabab, are the factors that control the cardiac output, And you could tell this from the definition. The volume of blood pumped out by each ventricle, that is your stroke volume. Per minute is your heart rate, combined together. So pretty much easy definition, right? Of course, cardiac output is the same for both ventricles. But don't confuse it with stroke volume. One more thing, don't confuse it with stroke volume, this definition. Stroke volume, we look into it, it says the same thing, but per beat, okay? And of course, cardiac output, Shabab, it pretty much means how much volume of blood can be pumped out. And of course, during exercise, it will increase up to 25 liters. Let's say 25 liters for simplicity's sake. How? By increasing the factors that affect cardiac output, Shabab. Heart rate, well, stroke volume. We know the heart rate, which is how much, how fast can your heart beat per minute. This is the heart rate, and stroke volume is the volume of blood pumped out by the ventricle per beat. We'll see as to how that happens. Okay? Of course, the maximum, we'll say 25 liters during exercise. Now, what about cardiac reserve? Cardiac reserve is pretty much how much blood can the ventricle pump. Like, what is its reserve? Its storage. What is its normal and what is its limit? So basically like this. The average, we said the average for cardiac output is 5 liters, and we will say that the maximum is 25 liters. So this range here, Shabab, is the cardiac reserve. It is the difference between the cardiac output at rest and the maximum volume of blood that the heart can pump per minute. Okay? How much it can pump per minute. And cardiac index is the cardiac index is pretty much cardiac output, but this time you're measuring the cardiac output according to the person's body mass or according to the body surface area. Everybody's cardiac output for everybody is different. So, for example, my cardiac output is going to be different from Hassan. So if I want to measure my cardiac output or Hassan's cardiac output, I have to do it per square meter per body surface area. There is a calculation, but it's irrelevant for Mid-2, I believe. All you have to know is the average, which is 3.2 liter. You basically measure the height and the weight. Okay? So the cardiac index. And of course, these we've seen before in past lectures. I mean, we've seen this before. As we said, don't confuse stroke volume with cardiac output. The definitions are similar, but don't confuse it. And of course, we talked about the ejection fraction, which is pretty much stroke in percentage. You want to measure the stroke in percentage, basically. And it's pretty much what we use to have like a measure of the ventricle function. Of course, if you look at previous physiology slide, just one thing to notice In the physiology slide, you use 60 to 65%. Here is 50 to 75%. It's not fixed. In my opinion, just go with 50 to 75%. This is the most recent. If it comes in a minute 2 exam, okay? Both are correct, but as we know in physiology, no number is fixed. Okay. Now we will go to the most important part, Shabab, the cardiac output, the factors that control the cardiac output. Shabab, the majority of this lecture is going to be talking about the heart rate and what are the factors affecting it, the stroke volume and what are the factors affecting it. If there are factors affecting the heart rate and stroke volume, you're basically having factors that affect this cardiac output, okay? So we'll start one by one. We'll start with the factor, which is heart rate, okay? So as we know from past physiology lecture about the heart rate, we took a little bit of an idea of it in the first 2 lessons of physiology. We said before that the heart rate, like imagine this, okay? Imagine this is your parasympathetic, and this is your sympathetic. And they're having a tug of war. They're holding rope. This rope, ya shabab, is the SA node. And basically, what your heart rate is determined by, what are the factors that determine your heart rate, is thanks to your nervous system, your parasympathetic, your autonomic nervous system, your sympathetic and parasympathetic. And what's happening is that your heart rate is constantly being monitored by the parasympathetic and sympathetic. Now, it's innervated by both. The parasympathetic pretty much inhibits the SA node. It inhibits the SA node. It decreases your heart rate. How? Do you guys remember the pacemaker potential? How it decreases the slope? So here's the pacemaker potential. Instead of minus 40 millivolts, let's say it becomes minus 50, for example. And it pretty much decreased permeability of calcium and sodium. So delayed depolarization. And sympathetic does the opposite, okay? Does the opposite. That's pretty much your parasympathetic. It affects the SA node by inhibiting it. Tamam? Inhibits the pacemaker potential. While sympathetic does the opposite. Sympathetic increases your heart rate. Okay? It increases the and of course, one more thing, increases the strength of contractility. Here, it decreases the strength of contractility. When I say decrease or increase of contractility, I mean the ventricle contracts. But what is the strength of contraction itself? Is the contraction strong or is it less? Okay? But the one thing that we haven't seen from past physiology lecture other than this, Shabab, is that which part of the heart do parasympathetic and sympathetic supply. So if we draw the heart real quick, the parasympathetic, and if we draw the SA node, that's SA node, AV node, bundle of His, Purkinje fibers, right? And if we just take the red color, all right. So basically, hold on. Let me draw the SA node a little bit more. So AV node, SA node. Okay, perfect. So basically, Shabab, we haven't seen from past physiology lectures what the nervous system, what does it affect part of the heart. Surprisingly, Shabab, the parasympathetic will only supply the atriums. The parasympathetic will only supply the atrium, and basically the atrium contain what? SA node and AV node. It has nothing to do with the ventricles, okay? Because its only connection is with the SA node and the AV node, a little bit of the AV node. Well, sympathetic, Shabab, the only difference is sympathetic innervates all of it. It innervates all of it, okay? So it innervates the atrium, so the SA node, the AV node, and the ventricle. So if we look at the table...
بالله إذا ما عليكم أمر ممكن نكمل بعد الصلاة.
طيب ما فيش مشكلة.
Just take a break for prayer, please.
ما فيش مشكلة، نعمل بريك حد الصلاة.
ما عندكم مشكلة عمران شباب؟ You all good?
عبد المجيد صوتك بعيد ترى ما نسمعك.
أقول إذا ما عليكم أمر ممكن بس ناخذ بريك ونرجع نكمل بعد الصلاة.
أنا بالنسبة لي it's okay. شوف الباقي.
There's only like one other person and he's quiet.
ما في مشكلة.
I don't know who is صراحة. شوف نواف do you mind؟ أنا it's okay يعني I don't mind.
I don't mind. بعد الصلاة ما فيش مشكلة.
خلاص يعطيكم العافيه.
اوكي ناخذ بريك نصلي ونرجع. اتس فاين فور مي. اوكي.
تمام.
اوكي خلاص حلو يلا مع السلامه.
نواف are you there?
اي هلا.
Who is R? مين هذا؟
اتوقع ده ممكن رعد.
Yeah, I think maybe رعد.
رعد.
لا بس رعد هي اتوقع سحب السمستر هو ما كمل معانا سكند سمستر رعد.
ما ادري ممكن في طالب تاني اسمه رياض، ممكن هو ده احد
maybe رياض.
احد اسمه بالار.
Yeah, I looked in the group. دخلت الممبرز حق الجروب. I'm looking for someone who his name start with R. ما لقيت عشان كذا سألتك. عرفت؟
انا ما ادري، ما عنديش مشكلة اصلا احد يدخل.
No, just for knowing. أنا just للمعرفة بس للنية. Yeah, I'm gonna go pray.
تمام. شوف بعد يعني 8:30 كده، 8:30 أو 8 إلا تلت.
وال أشكرك والبريك نص ساعة.
بعد الجميع يجي. أنا حبش أصلي الحين، أنا نفسي نرجع.
يلا يتقبل الله يا برو، حتى أنا ماشي.
تمام.
يلا.
No.
Guys, are you there?
Hello, عمران.
عليكم السلام. عندنا دوام على 10:30.
ايه ناخذ يعني بقينا بس نص سلايدز وهي كلها سهلة، معظم السلايدات الباقيين سهلة، نكمل فيزيولوجي وخلاص.
Let's go.
اصبر ما حتاخد وقت كتير. هنكمل. إيه بس
Let me jump here.
كده. طيب وقفنا في وقفنا في الهارت ريت. وقفنا في الهارت rate, and we said before that, just to as a quick summary, we're talking about the cardiac output and the factors controlling it, the stroke volume, and the heart rate. We said the heart rate is controlled by our autonomic nervous system. So parasympathetic and sympathetic. Sympathetic wants to decrease the heart rate by inhibiting the SA node, while sympathetic wants to stimulate the SA node by increasing the heart rate. And contractility, of course. And we said before that the parasympathetic, that it affects what? The parasympathetic only concerns itself with supplying the atrium, so the SA node and the AV node, while ventricle does not. The sympathetic system will innervate the entire the entire heart. So AV node, SA node, and the atrium, and the ventricles. If you look at this table, just pure memorization, really. Just something to keep in mind when it says decreased rate of depolarization in the threshold, it means decreased pacemaker potential. Of course, decreased heart rate, axial sympathetic, AV node, decreased excitability, increased AV node delay, axial sympathetic. Ventricular conduction pathway, no effect because we said that it doesn't innervate the ventricle. Here is increased excitability, increase the speed, bundle of His and Purkinje fibers. Atrial muscle from the parasympathetic decrease, here increase. Ventricular muscle, no effect. Sympathetic increase. Adrenal medulla, no effect. But adrenal medulla for sympathetic, طبعا, because the adrenal medulla is the site for synthesizing epinephrine. And of course, parasympathetic stimulates acetylcholine, no relation with adrenal medulla. The veins, it has no effect, but sympathetic does vasoconstriction or vasoconstriction of the veins, which actually increases the venous return. When we say venous return, we mean the heart getting increased amount of blood from the veins, increased amount of blood through the veins. That's increased venous return through sympathetic stimulation. How? By doing vasoconstriction. Yes, it's the opposite to the arteries, and we'll get into it. Okay, so this is pretty much the table. And that's about the heart rate. And of course, if we talk about even more, let's erase some of these. As we talk about the heart rate, determined by balance, under resting condition, parasympathetics dominates. And the other factor about the control of heart rate, I guess you could add another one. You could add another factor, and that other factor is epinephrine levels. Another factor that affects the control of the heart is epinephrine levels, EL, epinephrine levels. If epinephrine levels are high, increase heart rate. If it's low, decrease heart rate. That's another factor. But the main factor are the parasympathetic and sympathetic. Now we talk about the stroke volume. Now, for the stroke volume, that's the other factor for affecting cardiac output, the volume of blood pumped by the ventricle per beat, and is divided into intrinsic control and extrinsic control. Now, if I want to, actually, yeah, let me erase some of these so I can better show you the extrinsic control. So the intrinsic and extrinsic control, what's the difference between them? Extrinsic control refers to something outside the heart controlling it, which is referring to mainly the sympathetic system. Well, intrinsic control refers to what's occurring in the heart. What are the regulations in the heart itself that regulates the stroke volume? So stroke volume is subdivided into two factors controlling it: intrinsic control and extrinsic control. Intrinsic control, you could say, is related to venous return, which is related to preload, and peripheral resistance related to afterload. Now, what does preload and afterload mean? Preload pretty much means it is pretty much the same as end-diastolic volume. It is the amount of blood or the volume of blood in your ventricle before contraction. Like how much blood is returning to the left ventricle for contraction. That's preload. So it's like squeeze. How much blood will squeeze. While peripheral resistance it's familiar with the afterload. What is afterload? Afterload is the load. It is the load or the pressure in the aorta that the left ventricle has to pump against in order for blood to flow. So pretty much when you think of AL, you think of atrial pressure. You think of atrial pressure. While preload, you think of EDV. Same thing. Yeah? So if, for example, if there is an increased afterload, for example, when we say increased afterload, we mean increased atrial pressure, like in hypertension or aortic stenosis. There's increased afterload, that means your heart has to pump harder for better contraction and for better pressure or greater pressure than the aorta in order for blood to flow through. Okay? So that's intrinsic control related to the preload and afterload, and we're going into detail. Extrinsic control, sympathetic system mainly, and they both, of course, affect the stroke volume by increasing the strength of heart contraction. Okay, we'll look into that. So we'll start with the intrinsic control. So intrinsic control is pretty much referred to the stroke volume, like I said, the stroke volume and the end-diastolic volume having a relationship with one another. So the preload has a relationship with the kind of, not the afterload, but the stroke volume. Basically, like I said before, how does the left ventricle overcome the afterload? By increasing its pressure against the aorta. We said the afterload is pretty much the pressure on the arteries. If it's greater, then the heart has to contract harder. If it has to contract harder, what does this mean for the stroke volume? The stroke volume has to increase. Okay? And they pretty much, it's not afterload related to afterload. And in intrinsic control for stroke volume, there is a correlation. There's a relationship between the end-diastolic volume and the systolic volume. Okay, so let me draw the heart then. Okay, so if we could draw the heart here, and if we draw the septums.
Beautiful heart.
Beautiful heart indeed. Just imagine this is the entrance to the aorta, this is the aortic valve, the atrium, the ventricles, and let's draw in the blue color let's say the pulmonary veins, or let's say the superior vena cava. Same thing, veins draining deoxygenated blood or oxygenated blood. It's, of course, the vein for the pulmonary are going to be in red because they carry oxygenated, but I'm going to draw blue for simplicity's sake. Okay. And instead of drawing 4 pulmonary veins, I'm going to draw just one big pulmonary vein to make it simple. Better understand it. So this is PV. And this will be, by the way, your venous return. All these are venous return. Venous return, we said before, that is the volume of blood returning to the heart from the veins. The veins give blood to the heart, whether deoxygenated or oxygenated. And, of course, this depends. Is it increased? Meaning increased blood return to the heart, or decreased blood returning to the heart. Okay, referring to the veins. SVC, IVC. Okay, so we said the intrinsic control has a direct correlation with the end-diastolic volume. So we're going to say here preload, and stroke volume, which is not afterload, is related to afterload. Okay, if you want to overcome the afterload, the increased afterload, you have to increase the stroke volume. So we're going to say related to it. Like we said before, related.
هلا بس عفوا يا نواف. What's the afterload?
The afterload, it means the load or the pressure that this left ventricle has to overcome. How? By increasing its pressure in order to pump its blood towards the aorta. So when we think of afterload, Abdul Majid, we think of the artery pressure. We think of the mean arterial pressure. This is the average pressure in the aorta, for example. تمام? So for example, if there's an increased afterload, when I say increased afterload, I mean increased pressure in the aorta, then the heart has to contract much more, has to create more pressure, greater pressures in the aorta.
I can't even do that business.
All right,
So I'm thinking.
no problem. Okay, so we say it's related to the afterload. Okay, how is it related with one another? Well, it related to its length tension relationship. Again, when we refer to lengths, we're going to refer to this as end diastolic volume and tension. We're going to say this as pretty much stroke volume. Okay, so what do you mean by length tension relationship? Okay, Shabab. So I'm going to draw this in black color, the direction of the blood. And let's say over here, you know what? Let's have over here first an opened mitral valve. Okay, open mitral valve. This one is closed. Okay, we're just going to focus on the left side. Now, if we draw this in red color, I'm going to do the direction of the blood. When blood is drained from the veins, okay, when there is blood draining into the veins, and there's this increased volume of blood that's returning from the veins to the left ventricle, tamam? And let's say the end diastolic volume by the end of diastole becomes 130 milliliter. Shabab, when this blood drains into the left ventricle, what happens to the cardiac muscle fiber? Do you guys remember actin and myosin? Here's the actin and here's the myosin. Kind of like here, if you could imagine it, and pretty much it's like an elastic band, pretty much. When there is blood coming towards the left ventricle, this ventricle is like an elastic band. The actin and myosin are gonna stretch. They're gonna stretch more and more and more because of this pressure, because of this volume of blood coming towards it. So basically, the length of the cardiac muscle fiber is going to increase. And like an elastic band, or let's say like a rubber band. Sorry, like a rubber band. Like a rubber band, when you stretch it, doesn't tension be produced? So the more you stretch a rubber band, the more tension is produced. And the idea is the exact same thing for the ventricle. When you bring blood from the end diastolic volume, from venous return, when more blood comes towards the veins, towards your left ventricle, and more blood pumps in the ventricle, you're increasing the length. Why is it increasing length? Because the muscle is relaxing. It has to contain all this blood. It has to make room for all this blood. So the more length, the greater the tension. The greater the length, the greater the tension. But Shabab, if we say it's a rubber band, we said a rubber band has a limit. There's a limit to how much you can stretch, or there's a limit how much tension can be produced. Sorry. So at this point, it has a maximum tension. You can increase the amount of blood in the left ventricle. However, there is a limit in how much tension can be produced. Meaning what? There is a limit in how much your ventricle can contract, and this is important, especially in people with aortic stenosis. As we've seen before, they have to contract more. There's a limit to it, and we'll see. So if we look at these next slides, these next points, cardiac muscle resting length has a limit. When it says optimum length, it means the maximum limit. It makes maximum limit, meaning it can increase the length. You can have as many blood as you want in this ventricle. However, there is a limit at which maximum tension develops. So before I go to the table, when you increase the cardiac muscle fiber closer to its optimal length, you increase the contractile tension of the heart. When I say tension, you mean contraction as well. Tamam? The more blood is in the ventricle, the more it has to contract for stroke volume. Okay? So let's look at this. Let me look at this table real quick before I proceed. Okay? Before I go back to the previous slide. Okay. So you can see here, this is the end diastolic volume. In diastolic volume, the more it increases over here. And it can increase as many as you want. However, you see the tension in the y-axis. You see the tension. It can be produced. If the length increases, the tension will increase as well. More contraction. However, there's a limit. This optimal length is your limit. If the optimal length, if your end diastolic volume is more than, let's say, 400 milliliter, then your tension will actually decrease. Why? Because it can't pump, like let's say 350 milliliter blood. Your stroke volume will decrease. This means your tension will decrease. So it's like a rubber band. It has a limit in the tension. So if you're going to have maximum tension, you should have your cardiac muscle length fiber stretch it before the optimal length. This is what it means by this slide right here. You should have it closer to the optimal length, not after. Okay? That's your limit. So this is all good, right? This is all good, right? Having it be stretched, having to produce this tension. This means contraction needs occurring, which also, of course, needs more oxygen demand for this type of contraction. And of course, if you want to talk about the intrinsic volume or the intrinsic control of stroke volume, instead of saying direct correlation, you could say it's related to this law, Frank-Starling law of heart, which says that the force of contraction, meaning your tension, tamam, is equal or proportional to the initial length of cardiac muscle fiber. When we say tension, we obviously refer to the stroke volume. And when we say end-diastolic volume, we pretty much refer to the initial length. Why does the length increase? Because of the end-diastolic volume. Why does the tension, how much tension is produced and how do you contract according to that tension that's being produced? The stroke volume. Okay. So that's referring to it. Okay. And of course, like I said before, the greater diastolic filling, larger the end-diastolic volume, the more hard to stretch, the longer the lengths before contraction, more will be the tension produced, more will be the force of contraction, which means increased SV and increased SV. Yeah, increased SV. Okay. So we've said all that, right? We said that pretty much the intrinsic control of stroke volume depends on the basically mainly increasing the preload. Okay, and we said the preload is pretty much in diastolic volume. So if you want to increase the stroke volume, you have to increase the end diastolic volume. And we said that the end diastolic volume, the amount of blood that can come towards the ventricle, is from the veins. So if you want to increase the end diastolic volume to, let's say, 160 milliliter, you have to increase the blood flow from the veins. You have to increase what? The venous return. And there are many factors affecting the venous return, okay? So pretty much intrinsic control, meaning what? Meaning the heart itself, its length and its fiber. And what is its relation with stroke volume? What is its relation with end diastolic volume? Tamam? Length, end diastolic volume, tension, stroke volume. Okay? Simple as that. Any questions? Let me know. I'll answer you immediately if I have to. Okay?
So basically you're saying ان عندك شيء عمران؟
Go ahead بعدك.
تمام. So basically you're saying if the more venous return we increase, the more there is tension in the heart. When there's tension, the heart expands. If it expands, more blood is inside. بعدين بيضخ الدم, leading to more stroke volume.
Yes, you're correct. You're missing just one more point, that when there's increased venous return, increased end diastolic volume. Like I said, more blood returning. Because if you increase the venous return, you pretty much, there's a mechanism on the vein from sympathetic stimulation that will increase the venous return. More blood pumps towards the left ventricle, more increased end diastolic volume, and then what you said after that. That's right. Pretty much.
Good, thank you.
No problem. And especially this little line right here, Shabab, that's what I said before, extent to filling, ventricular filling, in diastolic volume. Okay? So now, in this next one, we're going to be talking about basically the factors that affect the venous return. Whatever factor affects the venous return will directly affect the end diastolic volume, like I said before, which shall affect the stroke volume. Because as we said before, increase end diastolic volume, you stretch the lengths of the muscle fiber. This will produce tension to a certain point, to a certain limit. And this means there will be increased stroke volume. Why? Because your heart will have to contract. This means when it contracts, what about the stroke volume? How much blood is going to be pumped out? Like 160 milliliters compared to 100, for example, is going to be here. Let's say here 130. Okay, well, in 100 milliliter is going to be like 80. So the stroke volume increase on this side. Okay, and of course, increased stroke volume means what? Increased cardiac output. As we said, SV is one of the main factors, along with heart rate, in affecting your cardiac output. So in the next slide, Shabab, we're going to be focusing on, we said this is intrinsic control, and this is extrinsic. In the next slides, we're going to be talking about specifically the venous return related to your intrinsic control. Okay? I mean intrinsic control. Intrinsic, and honestly extrinsic control as well, but mainly intrinsic, because what they're affected by is related to the sympathetic stimulation. We'll see. I don't want to complicate it. So let's talk about what affects the venous return, which directly affects all of these factors. Okay? All these factors. So now, let's look at the increased venous return. Now, if I could erase some of these quickly. Let's actually keep this. I'll keep it. Okay, and we will have the increased venous return. Now,
Delete the bullshit and keep the masterpiece, huh?
Yep. We're going to increase the masterpiece. Okay. So what are the factors that affect venous return? What are the factors that affect the return of blood, whether deoxygenated from superior and inferior vena cava or oxygenated from pulmonary vein? Pretty much, what are the factors that affect the flow of blood from the veins going back to the heart? Okay, the first one is absolutely increased blood volume. Oh, my bad. Increased blood volume. And increased blood volume, basically, we have these veins. So let's have a vein right here. And I want to talk about its structure compared to arteries, okay? There's a difference between it, between arteries and veins. So you guys know when, other than the heart, for coronary arteries, you know how arteries, when they get stimulated by sympathetic system, they get vasoconstriction. And when that happens, there's decreased blood flow. I mean, actually, yes, there's decreased blood flow, but also vasodilation. Vasodilation does what? Increases blood flow. So let me undo
لا
this.
لا تلخمني لا تلخمني لا تلخمني
لا انا عايز اعمل
الحين
comparison. بدي اعمل comparison بينهم عشان تعرف الفرق، عشان ما
Yeah,
تلخبط.
but there's a big difference between the increasing the constriction and the blood flow. عكس بعض.
ايوه عكس بعد. اللي بدي اقول انه الفاسودايليشن لما تحصل في artery في increased blood return، تمام؟ arterial return.
ايوه direction.
ايوه ولكن الارتري is a blood reservoir. ف when there's vasodilation occurring in the veins, you know, the veins could actually store blood, not like stasis, but like go much slowly like this.
Basically blood reservoir, as you said, but
Pretty
you
much.
meant the veins, not the arteries.
Yes, the veins. So when vasodilation occurs in the veins by sympathetic system, basically what happens is that there's actually decreased venous return because it's keeping some of this blood. So there's actually decreased venous return. It's only when you do the reverse of arteries that you do vasoconstriction, and now you're pushing all this blood. You're going to push all this blood that it's stored, and it's going to go fast towards the heart. So you're pushing it, and you're going to increase the venous return to the heart by vasoconstriction. So it's the opposite of arteries, the veins, okay? Due to its capacitance. Capacitance means storage, okay?
We're talking if we increase the vasoconstriction in the veins, not the arteries, صح?
Yes. If you increase the vasoconstriction, actually there's... what you say? Go ahead.
Generally, when the sympathetic system acts on the vessels, if it acts, يعني, does it act on both ولا الارteries لحال والveins لحال?
It activates on both, actually. Basically, in like, let's say an exercise, what happens is that your artery will cause vasodilation to increase the blood flow, increase the return, while your veins at the same time will be vasoconstriction. The opposite one another, but both do the same thing, increase blood return to the heart.
Oh, okay. So علاقة طردية.
Yes, basically. But now we go to one of the factors. Now that we know how like venous return is affected by the veins structure, all right. So one of the factors is, if we get some of these out and read it, is one of the factors that affect the venous return to the heart is increased blood volume. Here's the thing. When it comes to pressure, what affects your pressure is, we said before, vasodilation, vasoconstriction. So the compliance of your walls, same thing. Another one is the volume of blood. If there's increased volume of blood, too much of it, what will happen to the pressure? It will increase. So the veins have a limit, يعني. 60% to 70% of blood. If you increase the volume of blood in the veins, it will forcefully push all this blood. It has to. It can't keep all of it. It has a limit. So you could actually increase your venous return by increasing the blood volume, even if it's vasodilated. Okay? Now, what could increase the blood volume? What could increase it? Inflammatory fluid, from interstitial fluid. So we could say fluid, interstitial fluid, edema. We could also say sodium and water retention from like aldosterone, if you guys remember from MSK. Sodium and water retention. Anything that increases the fluid, okay? Sodium and water retention. And these increase the blood volume. The more volume there is to the veins, the greater the venous return. Okay, that's one of the factors. Now, the other factor is skeletal muscle pump, of course. Skeletal muscles have many veins surrounding it, many arteries. And it's very similar to what we looked at the lecture before for physiology. Remember ventricular systole, when a systole compresses the arteries? For skeletal muscle, any skeletal muscle when it contracts, compresses the veins. But actually, it will not decrease the blood flow like in the arteries. This is a vein. When you compress it, you will actually increase the venous return towards the heart. So skeletal muscle pump is another factor. Okay? What about respiratory pump? Now, this one doesn't go specifically what, and I feel like I should say it right now to make it easier. One of the factors is respiratory pump, Shabab. When it says respiratory pump, basically, you know what happens to your diaphragm? When you inspire, your diaphragm will descend down, right? So it will decrease the interthoracic pressure. So when your diaphragm descends down, it will compress some blood vessels in your abdomen. So it's going to compress some of the abdominal veins thanks to your diaphragm descending down. And this will squeeze all this vein upwards. And of course, it can squeeze it upwards. Why? Because the veins have valves. They have valves to prevent backflow of blood. So basically, your diaphragm right here, it descends down, and it will compress the arteries. The veins. Also arteries, but mainly veins in the abdomen. And it will push all this blood in the veins, go up towards the superior and inferior vena cava. Tamam? And they have a one-way valve which prevents backflow of blood. We will see it. It's one of the factors as well. Okay, so that's the third factor. The fourth factor is sympathetic stimulation, of course. Sympathetic stimulation, when it causes vasoconstriction in the artery, there is decreased blood flow. When in the vein, the opposite occurs, increased venous return, okay? And then the other factor is cardiac suction effect. Cardiac suction effect pretty much refers to think of the AV valves. When the AV valve closes, because the ventricle pressure over here, let me draw it in black color. When this ventricle pressure right here is greater than the atrium, of course the AV valve will close, right? When it closes, it will actually close downwards. So it will allow for more space for this atrium. And this more space will decrease the pressure. And if the pressure is, let's say, 0 or -0, it's going to have less pressure than the veins. And as we said before, in order for blood to flow from one place to another, the pressure gradient has to be there. So this is going to be increased venous return. Why? Because the veins have a greater pressure than the atrium, because the atrium had the AV valves closed, which gives more space, enlarge the atrial cavity, decrease the pressure. Okay? Any question, let me know. That's pretty much cardiac suction effect. Simple as that.
Asma.
All right.
For the sympathetic stimulation, so if we say that the sympathetic is vasoconstriction to the arteries and vasodilation for the veins, then the parasympathetic is vasodilation for the arteries and vasoconstriction for the veins.
If you're parasympathetic,
يعني بحكم إنه عكس.
Yes.
So the parasympathetic is vasodilation for the arteries vasoconstriction for the veins ولا?
Parasympathetic actually does not vasodilation, almost vasoconstriction. Almost. It depends really. For exercise, for arteries, vasodilation. Sometimes. For the heart. And sometimes it's vasoconstriction, depends on inflammation. Just think, for parasympathetic system, what you could do instead is whatever you think the action for sympathetic stimulation is going to be the opposite for parasympathetic, to not confuse you. Okay?
Yeah, that's what's exactly I said.
Yeah.
فإذا الsympathetic vasoconstriction in the arteries, so the parasympathetic is vasodilation
Yeah.
for the arteries يعني.
You mean for the veins? For the veins. Vasoconstriction in the veins. Then vasodilation.
Vasoconstriction in the sympathetic.
Yeah, sympathetic on the vein. Like we said, there's opposite action on the vein and arteries. When sympathetic does vasoconstriction on the veins to increase the blood flow, increase venous return. Parasympathetic does the opposite. Just like that.
So the effect of sympathetic on the veins is vasoconstriction,
Yes.
and on the arteries also vasoconstriction.
There's mainly vasodilation. When I say depends, because there are times where it actually does vasoconstriction. Remember septicemia? How it does vasoconstriction? So, but mainly vasodilation, like you said. I like to say both of them. So you know which factor causes what and what. But yes,
Okay, well, that's new. Thank you.
no problem. Okay, so we said the cardiac suction effect. Pretty much AV valves closed. Decrease the atrial pressure is going to be less than the veins, so blood can return more, increased venous return. Okay? The last one is the venous valves themselves. Like I said before with the diaphragm. When the diaphragm descends down and compresses the abdominal walls, they have only one way. Why? Because there are valves to prevent the backflow of the blood. And they're especially important when the person stands up, because, you know, there's usually increased pressure. Hold on. Hello. Can you guys hear me? My internet just disconnected. Shit. Hello. Hello. Can you guys hear me? Internet. Okay.
Backflow, then what?
Yeah, my bad. My internet just went out for a minute. Okay, so
We good.
you got. I also
The
got.
last thing we heard was to prevent backflow.
Oh yeah. So, but by the way, I have only 5 minutes in the meeting, so I'll stop in like 4 minutes to restart if you have time. Anyway, in the venous valve, we said it prevents backflow of the blood. So it has valves. The veins have valves. Oh, listen. I want to draw it in blue, not to confuse. So the veins, pretty much like we said, when the diaphragm descends down, it compresses the abdominal vessels, the abdominal veins, and they go towards the inferior vena cava, superior vena cava, whatever. And of course, they will go up when they're compressed and prevent backflow of this blood. Now, this doesn't increase the increased venous return. That's just part of its physiological structure, okay? So, but it's one of the factors affecting it, of course. This allows for blood to pretty much go forward, okay? Venous valves, as a result. Any compression, it will just go one way. And especially when a person stands up, because the pressure, when a person stands up, the pressure is going to be like very, very high in the lower limb, for example, in the lower part of the body rather than the upper part. So all these veins, if you want to return it back, you got these valves to let it go up and supply the upper part of your body as well when you're standing up. It's the opposite when you sit down. So if you want to increase some information. Well, so these are all the factors. And if we look at these from this picture right here, everything we said is right here. Everything we said. Of course, it includes this thing right here. It's the same thing, pressure gradient. You can ignore it if you want.
Can I try to explain them?
Sure.
عمران أنت عندك وقت؟
ايه عادي، بس عرفت اللي كنت بدخل افطر. تعرف انا ما اثقل فطور اول مره وكنت بتروش.
قلت نستاذن منك.
لا بدي حبي خذ راحتك معكم انا اروح.
حبيبي والله ما تقصر. طيب شوف so basically أنا ببدأ من اليمين ها؟ أنت قلت إنه السالت والواتر والضغط والهذا بيضغط على الفينز which increases the blood volume.
صح.
تمام. passive bulk flow shift of fluid from intestinal fluid into plasma. هذه وش قصده فيها؟
هذا قصدها يعني مثلا edema basically. مثلا edema يعني من inflammation. Basic inflammation. You know how interstitial fluid pretty much comes to the plasma?
Yeah, we're good.
Yeah.
Which increase the venous return.
Yeah.
تحتها يقول لك الريسبيراتوري بامب. قلنا لما الدايفرام يضغط على تحت ويضغط على الفينز حقت الابdominal organs which increase the venous return.
صح.
تمام. وفي skeletal muscle pump there are veins like in the muscles. So like when the muscles contract, they also contract on the freaking veins, which causes more pressure, more venous returns. As for the sympathetic vasodilator activity, you said that the sympathetic system causes the veins to vasoconstrict, increasing the pressure. If we increase the pressure in the veins, we have more venous returns. More venous return عن طريق السكشن effects راح ينسحب اكثر.
اي
صح؟
ايوه
في الارتري. بس الفينس كاباسيتي راح تقل لانها ما راح تكون متوسعه بتنضغط.
اي
تمام. طيب pressure imparted to blood by cardiac contraction.
هذا بس pressure gradient بس عادي ما يعني you could apply this to this as well or you could apply to skeletal muscle respiratory pump. This talks about everything. So pressure gradient in
Yeah,
general.
but بالكاردياك كومبريشن قصته لما ينضغط الهارت في جهه الجهه الثانيه تسعبها زي ما انت قلت اول ولا كيف؟
Oh, the heart? No, you mean the coronary arteries?
It says cardiac contraction, so it means the heart.
But
You
pressure
with me?
imparted to the blood. أيوة.
بس
اي صح. Basically talks about the
صح.
آسف كلم يا عبد المجيد آسف.
Yeah, pressure imparted to blood by cardiac contraction. I didn't get this.
Okay, so it's literally talking about the pressure gradient between the veins and the heart itself. When the venous pressure is increased, it is also related to the cardiac suction effect. So pretty much when the venous pressure increases and it's more than the one in the left or right atrium, what's going to happen to the blood? It's going to be increased venous return. Because blood flow depends on pressure gradient from high pressure to low pressure. That's pretty much it. Simple as that.
زي ما قلت في الكاردياك سكشن افكت لما
Yes.
ينزل الدم كله ويقفل الفالز بيكون صفر وفي في الفينز راح يكون البريشر اعلى فتيكولايز بينزل الدم على الارتري
ايوه لاحظ
على الاتريا.
لاحظ هي بتتكلم يعني عكس الشيء يعني هنا بريشر هنا وهنا فينس بريشر نفس الشيء.
اخر شيء الفينس فالفز انت قلت لي انه الفالفز ما تخلي الدم يرجع to make sure that it keeps moving forward.
اي وبس.
If we increase the venous return we got increased end diastolic volume. The end diastolic period is basically when the shit start filling. صح؟
اي
Yeah, and the stroke volume is
بس-
basically the amount that we need يعني اللي جوه الدم before it pumps.
اي بس
صح؟
ثانية-
والكاردياك اوتبوت القوه اللي يحتاجها عشان يطلع الدم.
ايوه بس ثانية يا عبد الجليل حنعمل ريستارت ميتنج. السلام عليكم.
عليكم السلام ورحمة. اوه نواف يلا فيهم.
هلا طيب نكمل.
Yeah, we should when it comes to this part.
Yeah, we pretty much explained, summarized everything. Abdul Majid, everything is correct so far. Perfect.
خلاص.
Awesome.
خويكم بيجي وبعدين نكمل.
يعني ممكن دقيقة نكمل.
عمران
رحب.
كفو. لا ما ادري، اول كان في واحد معنا ما ادري مين.
ما ادري صراحه، موجود انا بس ابي افتحها من الايباد، عرفت؟
ما خلصت جروب 1 باقي
هذا اخر شيء
على فيسيو. كاردياك اوتبوت.
So now continue. So we've pretty much finished the intrinsic control, and actually in extrinsic control, one of the factors that affect the stroke volume. Stroke volume. We're going to get intrinsic control. now. We got extrinsic control. We're going to extrinsic control is something yani control outside the heart. What is outside the heart? The sympathetic stimulation mainly. And with the sympathetic stimulation in epinephrine, what it does is that it increases the heart rate, increases the contractility by causing pretty much vasoconstriction on the veins, vasodilation on the arteries, basically increasing the end diastolic volume, increasing the free load when we say end diastolic volume. Of course, increased contractility is due to increased influx of calcium, increased permeability of calcium L channels triggered by norepinephrine and epinephrine when it goes to the receptors. Alhamdulillah. And of course, here is basically an example of Tanya. So an example of sympathetic stimulation on the stroke volume is normal. And here is basically increasing the strength of contractility, for example, by increasing the influx of calcium by norepinephrine and epinephrine, for example, in the ventricle. When they contract, basically there's a stronger contraction, so increasing in stroke volume, even though they have the same EDV, for example.
دقيقة وش صار؟ ترى أنا انفصل عندي فجأة لا أشوفكم اختفيتوا.
فأنا أريد أنا وقفنا فين آخر مرة سمعتني؟
نتكلم عن الاكسترنت كنترول.
كنت على الصفحة هذيك بعدين فجأة اختفى كل شيء. أول في آخر شيء disconnected. لا تحت extrinsic يا.
أيوة ده extrinsic إيدي وقفنا هنا.
أي.
طب أنا حاجة أعيد مرة ثانية. So extrinsic control, we say stroke volume is subdivided into intrinsic and extrinsic control. خلصنا الintrinsic. Extrinsic control is something that's outside the heart. So mainly stimulated by your sympathetic system. And of course, as we said, we've seen what the effects of sympathetic stimulation on the veins in intrinsic control has an effect on your extrinsic control. And what it does with norepinephrine, when they go for mescaline, you know what does constriction in the first place? These alpha-1 receptors, this found in the veins. So they go to these alpha-1 receptors, activate them, increase vasoconstriction, increase the preload, which means more blood goes to your left ventricle, which means there's going to be increased heart contractility. Why? Because it has another function, beta-1 receptors in the heart. It activates many of those. Increases influx of calcium, so there's a stronger contractility, and when there's stronger contractility, there's increased stroke volume, and we will see what I mean in next slide. Okay, so sympathetics can help us in preload, and it can help us in increased contractility, help increase stroke volume. So here's an example. Okay, so if we delete some of these, we'll see that in a normal 135, 70 milliliter, same thing. And here we can see the effect of sympathetic system. There's the same amount of volume of blood in your left ventricle. However, because it increases the strength of your contractility due to the influx of calcium, activating of beta-1 receptors, basically increased force of contractility, the stroke volume is going to increase. So there's more blood being flushed out. Okay? And if we look at a case where the sympathetic system affects the venous return, increases the venous return, does vasoconstriction on the veins. So end diastolic volume increases, meaning what? Like Abdul Majid said, increased stroke volume, because now the heart is length is stretched, tension produced, has to contract more, increased contraction, has to contract even or pump even more blood out. Okay, so 140 milliliter was end systolic volume decreased or less than usual. Just showing you an example. You can curve like this or like this, with venous return or without venous return. Most likely this one occurs, the third one, because it affects the veins and the arteries. So now we saw the extrinsic control, increase the contractility of the heart. When we say contractility, I mean its strengths, طبعا. And sympathetic stimulation shifts the Franken curve, the Frank-Starling curve to the left. Basically, it increases the tension. We said the ventricular end diastolic volume. This is your tension, lengths, tension, and it increases the tension. The lengths might stay the same, but the tension increases by the sympathetic stimulation. Okay, so it goes up, 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 up. The curve goes up.
I'm gonna leave. Thank you, Nawaf. See you all, guys.
كتر خيرك عمران.
سلام.
So now we finish the extrinsic control. Just like that. So pretty much sympathetic stimulation is included, and it's involved in intrinsic control or venous return, isn't involved in extrinsic control, basically. Help in increasing the stroke volume. And that's it. We finished the intrinsic and extrinsic control of stroke volume. And the stroke volume.
So what do they mean by the sympathetic activity and epinephrine? Like why, بين قوسين, epinephrine?
Where's epinephrine? Oh, just as part of it. Epinephrine is part of sympathetic. Like, it's not just epinephrine, nor epinephrine as well. It's just showing an example of the hormones or the neurotransmitters, my bad, released by your sympathetic system. Just like that. There's no like special thing.
Yeah, good. But they just say it in like a creepy way, that's all.
Yeah.
Like in brackets and shit. Keep going. Thank you.
No problem. After that, we finished now what factors have controlled the stroke volume. Then we've looked at the factors that affect the heart rate. Then the two factors affecting the stroke volume and the heart rate affecting, basically, if there's something affecting one of them or both of them, you pretty much affect the cardiac output. And that's the majority of this lesson. Okay?
Nawaf,
Hello.
did we finish this lecture?
What, physiology? قربنا داخل lecture.
Okay, because I didn't was here when you are explaining the factor controlling venous return. So if you can please replay it or do it again after you finish.
اوكي انا هخلص بسرعه لان الباقي السلايدات سهله.
حسن.
Okay.
I want to explain it to you. انت نواف صححني لو غلطت. اوكي.
فهمت جاي اعمل سمري كويسه بس صحت شويه اعمل كويس ما تخاف.
I mean, really, I'm gonna re-explain it to him again, but I want you to correct me again.
Okay, no problem.
You good, Hassan?
Okay, so now after looking at the factors and everything, we now look at the ejection fraction. We already know this from before. Of course, if ejection fraction below 30%, that means it's an index of ventricular function. So if it's 30% or less, that means your ventricle is not working well. So this is gonna be heart failure. Now, you're going to know this from pathology. We're going to, if we have a pathology or pharmacology tutorial, I'm going to explain to you there is a difference in heart failure. There's something called systolic heart failure and diastolic heart failure. We will go to this in pharmacology and pathology, don't worry. Pharmacology mainly. But there's a difference, and this will help you in revision for pharmacology later on. But anyway, back to the slide, ejection fraction is yes. If it's low, it's an indication of heart failure. Now we go to the next one. It's pretty much methods of cardiac output. It only highlights the dye dilution method, the Doppler combined with echocardiography. I think this is important, maybe an SAQ, who knows. So dye dilution method.
When I asked doctor about it, he said just know the name.
Just know the name? Perfect.
Yeah, we don't have the concept here.
And okay, so this
Save you, Hassan.
Okay. So, if we erase it, we just know the names. Fick principle method, dye dilution method, Doppler combined with echocardiography. Perfect. Measurement of cardiac. Of course, if we look, this looks like a classic SEQ question right here. Conditions which altered your cardiac output, physiological, طبعا, muscular, emotional, posture, pregnancy. Posture like when you're standing, or how you cross your legs, something like that. Pregnancy, of course. If you're curious, of course, the first to increase pregnancy, cardiac output will increase to care for the baby. Posture depends, usually decrease for some areas of the body, depending on how you sit. And then pathological reason, hyperthyroidism, and this is related to pharmacology later on, but just know that T3 and T4, I don't remember which one, but one of these hormones are involved in vasodilation. When there's an increased amount of them, there's constant vasodilation, so there's hypotension. So if there's hypotension, then like we said before in physiology number 1 in septicemia, if there's too much of like very low blood pressure, your heart is going to attempt to increase it back up. So there's going to be reflex tachycardia. Your heart's going to pump more, increase contractility, increase heart rate. So it's going to increase the cardiac output. We'll know in pharmacology in more details. But this is hyperthyroidism, anemia, of course, fever, of course, self-explanatory. Decreased cardiac output, axial hyperthyroidism, hypothyroidism. They're pretty much one of the hormones.
Why fever though? Why fever?
Fever, because when there's a fever, you need increased blood flow. Okay. So in fever.
Why?
So, okay, let's say you have a bacterial infection, and let's say this bacterial infection occurs like, let's say generalized, like in the bloodstream, all over the bloodstream. And you got your immune cells, they're coming in, they detect this, and they pretty much authorize, not authorize, but the phagocytosis of some of the microbe represents some of the microbe to T lymphocytes, and then they will release cytokines. So one of these cytokines is to go to the brain. You remember the hypothalamus, which regulates your body temperature? You remember? Yeah. It pretty much, you release cytokines or signals to your hypothalamus in the brain, which is responsible for regulating your body temperature. And of course, it's going to want to increase or decrease this temperature depending, so that, why does it like increase or decrease its temperature? Because it wants to kill the microbe. Because if you put it at an unsuitable temperature, it wants to put a hindrance on the microbe. So fever is absolutely a reason for cardiac output, because if there's increased temperature, there's also going to be increased blood flow. I forgot another thing, vasodilation. So for pretty much vasodilation towards the vein, you need more cardiac output. More cardiac output, more blood goes towards the organs that may be damaged by a microbe, for example. So you need more blood flow to make sure that everything's fine. If you can look it up also in the internet as well. But for me, it's self-explanatory. Fever.
Fucking legend, Shukran.
Not a problem. Like I said, there's also videos. And this is also, I'm glad you asked, because this is actually related to septicemia. Actually, yes, this is septicemia. Remember septicemia, how the cardiac output will increase? It's a form of fever, kind of, towards the heart, coronary vessels. We'll get into it, but yeah. So hypothyroidism, of course, decreased cardiac output if there's any damage to the heart, anything that's damaging your ventricle. So if you have beautiful heart, real quickly, anything that damages this left ventricle, whether myocarditis, endocarditis, heart failure, systolic, diastolic heart failure, any damage to the heart valve, stenosis, aortic stenosis, mitral stenosis from acute rheumatic fever, arrhythmia as well. There's an irregular impulse. The ventricle cannot contract regularly. For example, arrhythmia like ventricle fibrillation, in which there's no contraction in the ventricle. We'll see this in pathology in more detail. So decreased cardiac output, arrhythmia, of course. Hemorrhage and shock. We said this before in physiology. And shock, we said this before in physiology, and we're going to see it more in microbiology. Hemorrhage, basically, hemorrhage like in coronary arteries, leakage of blood outside. So this will decrease the cardiac output. Maybe not just coronary arteries, any other artery, any other vein, hemorrhage, something like that. And that's pretty much it. Just simple stuff, just pure memorization. May come in ACQ. Very, very important. All of these. And they're all self-explanatory. Most of them, except for hypothyroidism, which takes a bit of an explanation. And this one, we've seen this in pathology. The only thing unique about this slide, I'm just going to say, is it talks about how the most common cause of heart failure is, other than myocardial infarction, is working against increased afterload. And this is what I mean by afterload. The load that your heart has to pump, it is the load or the pressure your ventricle has to pump against in order to pump blood. Like I said, the ventricle pressure has to be greater. It has to contract more to have a greater pressure than the aorta, than any artery. And we said it before in the next slide, load against which the ventricle has to pump. So an increased afterload means a problem with the arteries, like hypertension. So increased pressure, increased arterial pressure. Aortic valve stenosis. Actually, in aortic valve stenosis, the pressure does increase. in comparison to the ventricles. I just want to explain this very quickly about how the increased afterload in aortic valve stenosis. So basically, when you have aortic valve stenosis, we said that the reason there's decreased blood flow to the left ventricle is reduced blood flow, right? There's low pressure in the aorta. That is correct. However, the aortic pressure right here, the aortic pressure, even though it's decreased, so decreased blood flow to the left ventricle, it still has a greater, how do I say this? It still has a greater pressure than the left ventricle during systole. Because there's small amount of blood coming towards it, and it has enough blood for increased hypertension, but it doesn't have enough blood to pump blood towards the heart. Does that make sense? When there's aortic valve stenosis and there's a narrowing of the aortic valve stenosis, when the ventricle, it has to pump more blood towards the aortic valve. So the pressure will start to increase a little bit more, but it's not enough to give more blood to the heart. Not enough blood to the right or the left coronary arteries. Because let's say this is 60, and let's say 60, the rest is 0 decreased blood flow, but this pressure is still greater than the one in the left ventricle. So let's say the ventricle is 50, it has to contract more compared to this. This is the increased afterload. So the pressure in the ventricle is still less than the aortic pressure, despite aortic valve stenosis. That's pretty much it. Okay? So this is what it means. Working against heart increased afterload. Of course, the heart failure to pump blood against hypertension or aortic valve stenosis or myocardial infarction. And then the last slide is just what I explained before, was preload and afterload. So you can see preload, squeeze, afterload, eject this blood. Wants to eject the blood. Okay, what is the requirement to eject this blood? Okay, and that is the end of our physiology lecture. That is the end of it. We finished everything. Inshallah, kul khair. Any question, you can ask me. Other than that, Hassan can come in and get his request done by Abdul Majid.
Fucking legend, thank you. Yalla. Go to the slide حق الفينس return please.
This one.
ايوه حسن.
ايوه يلا معك.
ببدأ من فوق على اليمين. تمام.
اذا بدك تبلش من اليمين، بدك تبلش من السلايد اللي بعدها.
هذا يشرح كل شيء.
خلاص اوكي.
فينس ريتيرن. طيب الحين وش يقول لك؟ يقول لك السالت اند ووتر ريتينيشن. تمام. الحين when there is like salt and water retention هذا بيزود البريشر gradient والبلد فوليوم، لانه يكون في زياده في الدم. عرفت؟ انت الحين اللي يمشي في الفينز عندك البلد، عندك البلازما، عندك الاشياء، والسالت والووتر تعتبر مع البلازما. عرفت؟ فكثرت البلازما بيزيد البريشر جريدينت، بيزيد الفينس بريشر، بالتالي يزيد البلد فوليوم. فهمت معي؟
اوكي فهمت عليك.
فهمت علي؟ فهو بشكل عام انت الحين لو كان عندك دم اكثر جوه حقتك الفينز والارتريز، طبيعي راح يوصل دم اكثر للقلب، لان انت الفوليوم عندك اعلى من الاشخاص اللي غيرك. عرفت؟
اوكي.
the more blood volume the more venous return. Venous return means the blood that your heart gets from the veins. مو صحيح الفينز اللي تعبي الهارت، عندك السوبيريور فينا كافا والانفيريور فينا كافا والى اخره، اللي تعبي القلب. ايوه. فعندك passive bulk flow, shift of fluid from intestinal fluid into plasma. هذا basically an inflammation. لما يكون في inflammation تكون المنطقة منفوخة، صح؟ حسن معي؟
يب معك.
ايوه، لما تكون المنطقة المنفوخة راح يكون في ضغط على الفينز، ضغطنا على الفينز زيادة بلود فوليوم، زيادة في البريشر جريدينتس، زيادة في الفينس بريشر، وبيزيد البلود فوليوم، بيزيد الفينس ريتيرن.
اوكي
خلاص. let's go down to the respiratory pump. الريسبيراتوري بامب وش هي؟ basically it's the diaphragm. تمام. الحين الدايفرام لما تتعبى عندك اللنجز، مو الدايفرام ينزل على تحت؟
مظبوط.
ايوه لما ينزل على تحت هو بيضغط على الابدومينال اورجنز، بيضغط على الستومك، بيضغط على whatever. لما بيضغط عليها ايش معناتها؟ معناتها
هيزيد
البريشر
البريشر.
جريدينت ايوه اللي جوه الفينز اللي هناك زاد البريشر اللي في الفينز، بتتحرك بيزيد الفينس ريتيرن. بس في another point الحين you need to know that veins act as a blood reservoir.
اوكي،
عرفت يعني
يعني بيخزن البلد، يخزن
أيوه.
البلد يعني.
ايوه بيخزن البلد. فانت عشان بترجع البلد هذا للقلب لازم تزود البريشر اللي على الفينز.
اوكي.
بعد الريسبيراتوري بامب عندك السكيلتال ماسل بامب. الحين انت عندك فينز بين المسلز صح؟ ف when you contract the
مظبوط.
muscles بتضغط على الفينز، ضغطت على الفينز زاد الفينس بريشر، زاد البريشر جريدينت، الدم المثبت جوه الفينز راح يمشي على القلب وبيزيد البلد فلو وبيزيد الفينس ريتيرن.
اوكي.
تمام. synthetic vasoconstrictor activity. تمام. This is basically telling you انه your sympathetic system acts on your veins which causes them to vasoconstrict. If they vasoconstrict انضغطت الدم راح يندف للقلب.
اوكي.
as simple as this. فبس صح انه بيزود الفينس بريشر عندك، بيزود البريشر جريدينت، بس بينقص الفينس كاباسيتي. الفينس كاباسيتي اللي هي الستورج كاباسيتي، او لما تكون وسيعه راح تخزن دم كثير، لما تنضغط يصير الدم اللي تخزنه اقل. فهمت؟
اوكي.
ممكن ازيد بس
اللي بعده
بس ازيد one information زي قال بس زي انه يعني حسن السبب ليش يعني الفاسو كونستركشن زي قال عبد الجيب sympathetic stimulation هو عشان زي قالها انه هي blood reservoir. هي ليش اصلا blood reservoir؟ because its walls its elastic walls هي thin مش زي الارتري، فمكان فيه مسيح يعني سبيس كبير عشان الفينز يدخل فيها وتعمل كده سلو. فهي كده blood reservoir. مثل الارتيريال هي pressure reservoir لان هي تقدر تحمل البريشر الكبيره الثقيله جدا. عشان كده لما يجي بلاد فلو بين الليفت فنتريكل والاورتا ده قال دكتور شارك انه الاورتا حتعمل كده بالون كده الاستيك ريكويل، تعمل بالون كلها زي الفين بس مع البلاد. تمام وبس كمل عبد المجيد.
طيب pressure imparted to blood by cardiac contraction. تمام. So basically بيقول لك ان البريشر by cardiac contraction. انت الحين when your heart pumps بيضغط على نفس الفينز اللي فيه صح؟
اوكي.
That's it يا نواف. فلما يضغط عليها زود البريشر اللي فيها فبترجع اسرع للقلب صح يا نواف؟
ايوه لما البريشر في الفين يكون اكثر من الاتريوم عشان الاتريوم يكون ريلاكسد والفين يعني ما تكون حتى فاسو كونستريكشن يعني يكون عادي بس الاتريال اقل من الفين، فطبعا البلود فلو حيجي اكثر زي انت قلت. بس
يعني لما الهارت يعمل بامب كونتراكشن مره قوي حيرجع بنفس القوه هيك يعني.
يعني شوف يعني مثلا تذكر الايزوفوليومتريك كونتراكشن الكاردياك فيز السايكل في الكاردياك سايكل. ايوه الاي في فالف كلوزد تمام والاتريال ده حتكون ريلاكسد. لما تكون ريلاكسد ايش حيحصل للبريشر؟ ما فيش فوليوم بلد كثيره فالاتريال حيقل يكون نيجاتيف زيرو واقل من زيرو. فلما البريشر بيكون يقل حيقل من الفينس بريشر. فده نحن قلنا البلد فلو بتعتمد بالبريشر جريدينت من هاي بريشر الى لو بريشر والفينس بريشر more than the left or the right atrial pressure. فعشان كده البلد حيدخل جوا. تمام؟
ايوه اوكي
تمام. تفضل.
Then next we have the cardiac suction effects. The cardiac suction effect is basically it's all about the pressure gradient inside of the atria and the like the veins بشكل عام. انت الحين لما الدم بيتحرك من الاتريا وبينزل على الفنتريكلز الاتريا بتكون فاضيه تمام؟
اوكي.
بتكون فاضيه والفالف تتقفل على ناحيه الفنتريكلز. طيب الحين الفنتريكلز فيها ضغط عالي والفينز فيها ضغط عالي والاتريا الضغط اللي فيها صفر. automatically the blood اللي في الفينز because it has a higher pressure than the atria راح ينزل من الفينز للاتريا. بيعبيها.
اوكي.
عرفت to equalize the pressure. So basically, this difference in the pressure gradient causes a suction effect in which the blood in the veins is sucked into the atrials.
اوكي.
فهمت علي؟ واخر شيء عندك الفينوس فالفز. الحين نفس الفينز فيها فالفز مقفله ما تخلي الدم يرجع لورا، تخلي الدم make sure that the blood is moves only forward like towards the heart. It doesn't go backward, doesn't go بس سيده. فهمت؟
ايوه فهمت عليك.
فبتمشي سيده بتوصل للقلب at the end فكل دي الاشياء increases the venous return. الدم اللي يجي في القلب اللي يصب في الاتريا، زودنا القلب اللي يجي في الدم اللي يصب بالاتريا راح يزيد الانdiastolic volume. الانdiastolic volume is basically the amount of the blood that is filled in the ventricles. عرفت؟
ايوه.
طيب كمية الدم اللي في الventricles. والstroke volume هو is basically لحظة لخبطت شوي. مو بالستروك اللي في الventricles يا نواف؟
ايوه يعني في الفنتركل، بس هي يعني اكشن، يعني لما يعني زي
هو الدم اللي بينضخ من الفنتركل للاورطه صح؟
ايوه ده عدد الدم يعني.
أيوة.
لما يزيد الانتاستوليك فوليوم عدد الدم في الفنتركل، طبعا الكريستروك فوليوم حيزيد. ليش؟ في زياده دم في الفنتركل، فهي يعني
حيزيد الستروك فوليوم.
ايوه عشان يعني مثلا اختلاف بين 300 ملليلتر انتاستوليك فوليوم 300 ملليلتر، وفي يعني فيز تاني بيقول لك 100 ملليلتر. ايش يعني زياده الاندستوليك فوليوم يعني your heart will have to contract harder to extract compared to this one. خلينا نقول 60. هنا لازم يعمل contract harder عشان يطلع كم 270 مثلا ملليلتر.
يا
So basically الانdiastolic volume هو الفوليوم اللي في نهاية الريلاكسيشن بيس حقت الفنتركلز. تمام؟
هو البلاد الموجود في الفنتريكلز after the diastolic period.
ايوه. والستروك فوليوم is the end amounts اللي في الفنتركلز
اوكي.
من بعد ما تتقفل.
هلا
والكاردياك
بس اسال انه الستروك فوليوم هو البلاد اللي بيكون موجود في الرابد والسلو الرابد سلو ايجكشن فيس صح؟
ايوه
في السيستوليك.
ايوه في السيستوليك بس يعني
في الرابد والسلو
يعني
اللي هو 70 النورمال.
يعني المجور يعني الاثنين مع بعض. ماجوريتي بيكون في الرابيد ايجكشن فيز اكثر، لانه الماجوريتي بلاد يعني بتمشي رابيد بيس. في سلو ايجكشن فيز يعني الفيلوسيتي يعني السبيد بتقل بس كده. بس مع الاثنين معاهم.
الكاردياك اوتبوت في الاخير هي القوه اللي القلب لازم ينضغط فيها بحيث انه يطلع الدم اللي في الفنتركلز. سو اذا كان الستروك فوليوم اعلى، الدم اللي في الفنتركلز مره كثير، the heart is supposed to have a higher cardiac output. It's supposed to contract harder على اساس to pump the blood.
اوكي تمام. يعطيكم العافيه.
Any question؟
لا يعطيك العافيه. انا لازم اقوم البس هنلحق الجامعه.
يعطيك العافيه.
نفس الوقت. شارع الملز بحدي جامعه المعرفه.
والله يا رب ما يكون في زحمه. بس هلا شفت نواف فتحوا الطريق فصار اسهل تروح. ما ادري اذا لاحظت بس فتحوا الطريق عملوا حفريات وهيك.
You both live in ملز؟
يب.
يلا سلام بالسلامه نشوفك في الجامعه.
يلا سلام. يعطيك العافيه نواف.
الله يعافيك.
يعطيك العافيه نواف.
الله يعافيك. نشوفكم في اللاب ان شاء الله اذا انا لحقت.